Laser Pulse is brought to you by BW Tech Medical, a leader in light-based devices for over 30 years. Whether you're a researcher or a manufacturer, we help turn ideas into reality. Learn more at www.bwtechmed.com.
Okay, welcome everybody to this edition of Laser Pulse, where, as you know, our intention is to bring thought leaders from a variety of disciplines to discuss the many uses of lasers in medicine, what the science tells us, and what we may expect to see in the future. Today, we've got a pretty large topic, actually, evolution of the surgical laser. And we've got somebody who's made a huge contribution in that field. And my co-host, Dr. Pryor, actually, luckily goes back some way with our speaker. So, Brian, why don't you help us learn a little more about Dr. Lanzafame?
Yeah, excellent. Thanks, Andy, and thanks everyone for joining. Yeah, today we're very fortunate enough to have Dr. Raymond Lanzafame. We'll say Ray because we go back a long way. Ray and I have been on the board of ASLMS together, have looked at some ideas together in various parts of laser medicine. But Ray is kind of, when I came into the field, read a lot of his papers. He's been around and has done a lot in lasers, not just in laser surgery, but in photobiomodulation and many areas of laser tissue interaction. He's published 4 textbooks and has published over 250 papers academically. And he leads, he's been involved in many various institutions and in societies. He's currently the chair of the Society of Robotic and Laparoscopic Surgeons, which he'll tell us a little bit about. And we're very, very happy to have Ray to kind of guide us down the path of surgical lasers and other, laser applications in medicine. So thanks, Ray. Thanks for joining us.
Well, thanks, Brian and Andrew, for inviting me. I think this is quite exciting, and thank you for the introduction. My grandmother would have been proud.
Good.
Yeah. So one thing, Ray, when we've worked together, especially at ASLMS, I was always very impressed with your very thoughtful approach to new applications, even new standards, right? I know you've been involved with a lot of the ANSI standards and other things, but you approach it in a way that's very thoughtful from each side. And I really learned a lot from that. And, there's a lot of parties from doctors wanting to do it one way, from standardizations and FDA wanting to do it potentially a different way. And you thoughtfully listened to everybody and brought the groups together in a usually harmonious way. So that's one thing that I really appreciate you bringing and teaching me over the years.
Thank you. I guess there's a bunch of scars and Kevlar, but I think really when you're talking about these technologies, are really anything that you're trying to use. You want to have a rational approach, and sometimes that's very difficult for people to see because you have all kinds of parties involved in that, and politics. You said a mouthful a while ago, and lest we forget, the 10,000-pound gorilla in the room is economics. So at the end of the day, you could have the best solution in the world. But if it doesn't net me income, I'm probably not interested in it, or as interested as I might be in it. And that is something that happens in healthcare and every other walk of life. And certainly in terms of trying to make things better. In terms of being able to care for people in our own life and lifestyle, it's important that people put things in perspective. So that's what I've tried to do. And in terms of my own work and research, I've always been interested in how things work um, um, how they're put together. Used to be really, really good. You could put a pin in something, animal, vegetable, or mineral, and I could tell you what it was. But why is it there? How does it work? Kind of thing. And in terms of my own academic interests, scientific interests, it's more a function of trying to do something useful, trying to solve a practical problem as opposed to, gee, I'll do this because it'll net 3 papers and 2 presentations in some warm, sunny place. So that's been how the mind works, or mostly is supposed to have worked over the decades.
What was first, what attracted you first getting into light and lasers?
So back in the day, as a surgical resident, at a point in time when I looked like an ice cream salesman, we had short white coats and white pants, shirts and ties. We had a period of time during the midpoint of our training where we had to be in the laboratory. And I had done research before in, high school, college, et cetera. So was interested in continuing research. Had published a couple of papers here and there. And was in the lab at the time, actually doing work in fluorescence, looking at tissue perfusion and tissue ischemia and so on and so forth. And so we had photographic methods and using various fluorochromes and so on, and looking for ways of determining the amount of injury that might be present. So how do you define that? Because you don't want to take out too much stuff.
Right.
You want the human or the animal to survive, but you don't want to remove so much intestine, if you will, if there's a problem that they can't survive because they can't element. And so fluorescence and photography and those sorts of things all came together as part of interest and so on. And while I was in the lab, the guy a year behind me, who ultimately became my boss as predicted, was interested in doing something related to burns. And so he had found out about lasers and talk to the boss. So Dr. J. Raymond Hinshaw, and Ray literally was a Renaissance man. First of all, he also had an eidetic memory. So it was not unusual to find yourself in a conference room sitting there, and all of a sudden the question would come across, Ray, you'll recall what so-and-so famous professor said 2 years ago at thus and such meeting. And was I there? Was I awake, et cetera? And, he could quote it from the time. But Ray was the kind of guy that nothing was too crazy. So if you had an idea, he'd find the money and the support when everybody else said you were nuts. And so long story short, Ralph Panino was interested in lasers. He approached a whole bunch of companies. And lo and behold, they finally came upon advanced surgical technologies, which I guess now you probably know as Boston Scientific, going through all of the various iterations. But anyhow, AST, which had a sharp plan laser. And at the time, there were 3 or 4 of these things in the country. And Ralph and Ray managed to sell snowed Eskimos. We got a laser on a buy one, get one, pay as you go deal. And the deal was that because we were ostensibly general surgeons, that they would place a unit in our lab so that we could train ourselves and the surgeons. And if we agreed that we would teach others and help publish and figure out what this technology did. So we were one of a few sites that had lasers. So while I was in the lab, I saw Ralph and a couple of other folks using these things, and it struck me that carbon dioxide laser at the time, a Sharpland 733 laser to be exact, orange and gray beast, um, was quite interesting in terms of what it did and how it literally operated. And I saw very early on, gee, this is going to be a very useful tool. I had to learn how to use that, which I did. And then ultimately, when I got out of the lab, all of the attendings in the hospital had been trained, but they weren't necessarily interested in actually operating with the instrument themselves. They were interested in seeing what it did, but they weren't necessarily interested in actually using it. And I was the guy that had the experience. So as we were operating and learning, they were more often assisting me as we were doing various things. And meanwhile, we were documenting all of this, and we were teaching folks in the area and literally around the world with various courses. And it kind of snowballed. Along the way, Isaac Kaplan himself had come to Rochester several times. On at least one of those occasions, he brought a little module for that 733 laser so that we could use milliwatts. And so that ultimately begat some of my Ray and some of the other colleagues in the lab doing some tissue fusion work. But similar to that, as time changed and we became more facile in terms of what the technology did, as new devices came down the road, people would show up on our doorstep with technologies. And you talk about evolution. So the first thing was the buy one, get one free. Then the next phase of that was, here, I have this thing, go see what it does. Okay, so yeah, we used it. It sliced, it diced, it did what we expected it to do. I was always interested in the tissue effects and wounds and so on. And then phase three of that was, so we have this device, you've used it, et cetera, et cetera. Will people buy it, and how much will they pay? P.S. That was probably one of the reasons why I went to business school and got an MBA. And then the next phase of that was, for $300,000, you can buy our prototype device and be part of our phase 1, 2, whatever clinical protocol. And so the evolution of that and that technology. But the point is that because we had developed a legacy, if you will, and a reputation of doing good clinical work, having the ability to teach, and being able to put the techniques and the technology into clinical perspective, we were sought after in terms of looking at other technologies, and we had done a preclinical work that various companies used for their FDA clearances and so on and so forth. On some occasions, working with multiple competitors at the same time, but without spilling the beans in the various with the various companies. So that's the short story. So that's where it all began. And as I said, it snowballed from there. As well as looking at it. So once you have a device and a technology, not to say that any technology is the hammer for the proverbial nail, but the question becomes, so I have this, can I do it better? Or how can I do it better if I use this technology? Or, does it make sense? And can we add technologies together to be able to do something synergistically?
And this was in the 80s, in the
Yes.
90s?
So I was in the lab in 1981.
Right.
Well, as a resident in 1981, I've been in the lab since high school, during high school. So going back a goodly long time.
Yeah, so you've seen a lot of different technologies come, a lot of different wavelengths, right? And a lot of, like you said, I think that oftentimes even now people think, oh yeah, laser's a laser's a laser. But different wavelengths do different things. They're good at various absorption. Was there one technology that you've seen, especially for surgery, that was most prominent?
So that probably needs a little bit of a historical asterisk. I have to tell one quick anecdote about that. So as a resident, presenting at the Society of University Surgeons meeting, Society of University Surgeons is a veritable who's who of academic surgical scientists in the United States, who at the time they've upped the age. You had to be 45 years of age academic and have at least 20 publications and be invited. But anyway, we were presenting our work on CO2 lasers, and at the same time, um, um, we had colleagues who were at Utah, and they were presenting work under the auspices at that time of John Dixon. So John Hunter, who is a friend, and he's gone really far in academic surgery, was presenting work using ND YAG lasers, which was what John Dixon was studying. And so after presenting this whole session on lasers, the professor, Claude Organ, also a great surgeon, remarked that we had decimated the North American supply of New Zealand white rabbits because we were working with animal models in both. And he asked John Hunter, why were you using a YAG laser? And he gave this very erudite answer, but the last sentence was, and besides, that's the only one we had. So some of it depended on what you had and what you were used to. But I'd have to say, in terms of incisional surgery, particularly if you're not talking about fibers and those applications, it's still a carbon dioxide laser. As a carbon dioxide laser, I think it still has the greatest degree of precision. Not to say that several other wavelengths are useful. And if you're talking about minimally invasive surgical, so endoscopic, laparoscopic kind of applications, you could use a number of different technologies, but in my hands, I found that the 532 wavelength and a fiber was the easiest to apply, or the most versatile to apply. If I was in a training mode, and I could select a series of lasers, which I could in my institution, probably a holmium laser was safer in the hands of somebody that I was training, particularly in the point in time as those were becoming available, because well, just the dynamics of working in the aqueous environment and so on made it safer if I was assisting a resident or having a resident assist me. I don't know if that makes
Yeah, no,
sense.
that's perfect.
Yeah.
We've been doing a lot of work, and recently we've been looking at some blue wavelengths because of the absorption in blood.
Right.
And we were doing some work with some veterinarians, which we've had on a past podcast. And really workflow, right? It comes down to workflow. If I have to use a scalpel and then put it down to pick up a laser, right? Oftentimes just it doesn't fit in work in that environment, especially. So I think, workflow, precision, there's a lot of various things that go into play of why you would use different wavelengths.
Right, but there's also, I mean, you said an important thing like putting down an instrument, and I know the audience listening to this is likely likely more sophisticated and understanding light. But um, I can't tell you the number of times in my career I've had somebody pick up, telephone, Mrs. Jones, Dr. Lanzafame, I called you back because I have condition, fill in the blank, something that requires an operation. But I don't want to have surgery. I want to have laser surgery. Will you see me? There was a time when they did literally mean laser, and then later laparoscope. But the point I'm trying to make is that any operation, most operations, still require other instrumentation. If you think about all the stuff on the back table, if you ever watch or see an operating room, there's a whole bunch of stuff that's there, instruments, some of which date back centuries, that still have their use. That's not to say that if I'm an ophthalmologist that I'm going to use those to operate the retina. That may be the one exception to maybe using a singular technology, start
Yeah.
start to finish. But very often what we do is a marriage of a number of different devices and technologies to get the job done.
Yeah. As you've seen, I think that lasers have various adoption rates, right, in various specialties. What's the biggest misunderstanding of surgeons have about lasers?
I think that, well, the one is that they're all the same.
Right.
The other is that they're no different than an electrosurgical device. I'm going to say Bovie, but Bovie is actually a registered trademark. Uh, but the point is that the technologies are all different, and how you apply them has various nuances and consequences. Some of that is also colored by just not having had exposure in using the devices as part of training. If you haven't seen it, used it, had an opportunity to use it during training, you're less likely to do so unless you have absolutely no other alternative. And I usually, again, I'll go back to ophthalmology. If you're an ophthalmologist in 1960, you couldn't operate on a retina. Well, maybe you could do a PRK with a blade, but along came lasers, and that you either embrace the technology or you just couldn't treat patients. In my discipline, there's a lot of different ways you can take out a gallbladder, or you can excise a mole, for example. I don't absolutely have to have the technology in most instances. So what you tend to use is going to be what's most readily available to you, and what you're most comfortable with, all else equal. Unless something comes along, when lap chole came along, um, folks said, "Oh, it's experimental surgery, et cetera, et cetera." And the point is, the actual operation, the physical removal of the gallbladder from the body, had been done for well over 100 years. That anatomic event hadn't changed. How they got there was different. And colleague after colleague would say, "Why did they go mess with an operation that I know how to do? I can take it out in X amount of time," and so on and so forth. But what started happening is people discovered that, if I'm on the business end of that and had my gallbladder done the hard way, not only do I look bad in a bikini to have a gash under my rib cage, and it hurts a lot, but I'm disabled for a period of time. So why wouldn't I go to the guy down the street who can do it laparoscopically. And so what drove that, like arthroscopy before, in terms of knees and the meniscus, was patience and patient recovery time. And all of a sudden, surgeons discovered that they were losing 25 or 30% of their business. So they better learn how to do this, or
Right.
they weren't going to be able to compete, if you will, or succeed economically. I had to go into a lot more detail on that, but I'm going to try and
Yeah, no, that's
try,
that's a
try and
good point.
encapsulate that. But that, I mean, I said it before and I'll say it again, that, that bottom line kind of thing does color what people do. And and it also hazard to say it also colors the kind of answer you get to the question of, so I have this condition, can you do it in this way? The answer you might get is, no, you're not a candidate for that. But the second part of that, it might be in some cases, well, because I don't do it that way. Um, but that isn't always the case.
Yeah, that makes a lot of sense. Um, we have oftentimes, as you know, we're very involved with photobiomodulation and have been, and you and I have done some stuff on wound healing and some interesting ways. And oftentimes in a new field or someone new to laser, you're explaining, how would you explain the difference between, say, the non-ablative, PBM and a surgical, for a new doctor?
Yeah. So I think well, you could get simple or you could get hard. You could try you could try to explain it like plants and photosynthesis, so something that's photochemical. Or if want trying to explain it to somebody who's going to ultimately be a dermatologist, the tanning booth, um, which may not be a bad thing, because there's pluses and minuses to that. But the point is that you're talking about something that's photobiologic, and to the best of our understanding, non-thermal, at least on a macro scale, non-thermal, as opposed to something that physically alters the tissue in a way, um, like a cut or an abrasion, something where you're physically removing tissue, or otherwise dividing, coagulating, et cetera. I don't know
Yeah,
if,
it's often hard, right? It's as explaining without getting into, very deep photochemical effects, to
right,
explain. But I think that's a good one. One, you're manipulating the tissue in some way, and one, is a photochemical. And then you got in between, right? Is with
right,
PDT or with
right.
PTT. And have you done any work, or do you think any notable applications in PDT or PTT?
Yes.
So what?
Over time, yes. Roswell Park is down the road, and so um, um, we went to Buffalo actually very early on, and met several times with Tom Doherty and others. Um, we actually had signed on to some clinical studies, and one of the iterations of what now is called porphyrin sodium, and work in the lab. We've also been involved. You fast forward over the past 10, 12 years, work with like what you would call antimicrobial PDT,
Okay.
among other things. So the short answer is yes, both clinically and otherwise. And I published back in the day a bunch of papers having to do with photodiagnostics. So back in the day film-based, but these days you can do that with CMOS sensors and so on. But the techniques and the technologies are the same in terms of the photo detection. So taking the concepts that I had worked out and learned with fluorescence, with fluorescein and other fluorochromes, and the ischemia stuff, and applying that with some of the porphyrins and other agents. Yeah.
Yeah, it's very exciting with now we have these very small microscopic cameras that you could put really anywhere. I think that's going to potentially change laser surgery, laser diagnostics, right? Even non-laser, but just seeing, down a scope and getting a really nice image. Have you seen that technology, and what's your thoughts about kind of the future of that?
Yeah, so that's been there for a while. The chip on the stick
Yeah.
that has been around, goodness, 20, 30 years maybe. And it's that has certainly become more practical, and certainly with LEDs and laser diodes, the price point for a lot of the technologies, so the drivers, so the excitation wavelengths, much less expensive. The rest of the electronics to boot. So I think that future is very real. I was involved with Eastman Kodak Company, I can say at the turn of the century, at the turn of the century. Well, before that, as a researcher, but as part of some of their medical innovation group. So it's not my fault what happened to Kodak, but the point is that we were interested in doing some of these things with optical molecular imaging and overlaying, so using native fluorescence or otherwise, or using some of the stuff they had in their list of chemicals at the time, that we could use for various purposes. So I think those things are very real. There are a lot of opportunities today with nanotechnologies, being able to link some of these things together with antibodies and so on, or in the physical chemical realm, incorporating some of these things into devices, suture materials otherwise, to be able to get to places that we couldn't before, or couldn't very easily before, arguably. And I guess on that score, one of the things that wow, all of a sudden people are waking up. There's an article that appeared in one of the SPIE publications about being able to detect photons that went from one side of the skull to the other. It's like, well, okay, and, as a kid growing up, we still had flashlights. Nowadays they're LED powered, but if you stood in a closet and you put the flashlight, red yellow light came through, so you knew light was being transmitted. My point is that people weren't doing the experiment properly. If you put a point source, Brian understands the physics a lot better than I do, but getting the light through my thick skull and seeing it on the other side, you better have a very powerful detector. So a lot depends on the size of what you're doing, and how you're applying that to tissue. So I think people are waking up to some of these things, or maybe they're becoming more receptive. I hope they're becoming more receptive.
Yeah, I think so. I think I think there's so much going on, right? There's a lot of research. I think finding that killer app is important, but I think you're right. People are more receptive to trying. I think with photobiomodulation, certainly not quite mainstream yet, but getting there, right? It's mainstream in vet medicine, right? It's funny.
Right.
I sit on a
Yeah.
plane, I talk to someone, and we start talking what I do. It's inevitable that, oh yeah, my dog's got that done.
Yes.
So it's great that, we love working with veterinarians because they will try different stuff. The economics are different, right? So it's a whole different realm, but it is a good way to introduce some things
It
in this
is.
space.
Yeah.
Especially wound healing. Have you seen in your years of surgical laser, right? Surgical, so it could be bloodless. There's a lot of reasons to do laser, but have you seen the wound healing aspect of it? Less wound, but does that come into play not only the way the surgery is done, but is photobiomodulation potentially a part of that?
Yes. So yes to both. Operating incisionally, operating and using the technology properly. So if I'm operating with a carbon dioxide laser, for example, and I'm raising flaps, the ability, first of all, to be very precise in doing that, but also having less thermal damage, but being able to seal vessels and lymphatics along the way has benefits in terms of reducing seromas and so on in the long haul. So that's different from what these days is the state of the art with folks using electrosurgical devices. The wounds do behave differently. The ability to operate on contaminated or infected tissues certainly improves that. True, the technologist and the technique are as important as the tool, but you can get better clinical results, I think, in terms of the aesthetics, comparing apples to apples. And then in terms of improving the wound healing process, yes, there's several ways to do that using PBM techniques and technologies. So on the thermal end of it, you probably have some interplay of heat shock proteins and so on amongst the other physical things that I just talked about. On the PBM side, there are a number of wavelengths, but particularly in the red and the NIR, that are quite beneficial in terms of wound healing. Most obvious, I guess, would be in the kind of chronic wound where folks have seen that. There's a caveat to that I'll get to in a minute. But in terms of the standard incisional wound, it does make a difference as well. I know there was a technology that Serge Mordaunt and his group in France had tried to promote, using a diode laser on surgical incisions. They actually published it as LASH, laser assisted scar healing. I don't think the device ever took off, but that was probably a hybrid in terms of being PBM as opposed to a little bit thermal. But the point is that concept is very real, and you can demonstrate that. We've demonstrated that in laboratory in various animal models in terms of wound tensile strength and so on as collagen production. You can improve the quality of the wound even in quote unquote normal healing, and certainly accelerate that in terms of impaired healing, diabetic and others. So we've done that with diabetic wounds in humans and presented and published some of that work. But there you get back to, so the technology can do what it can do, but it can't do everything. So if I have somebody who has a pressure sore and it can go from an abrasion to I've got exposed bone, it's pretty foolhardy to think that I'm going to shine a light on something that's got exposed bone and it's going to heal. Yet people did that and it failed. And so the answer was, oh, this doesn't work. Yeah, no kidding. A rational person might not expect it to work, but unfortunately, that kind of information or misinformation, misapplication finds its way to the literature, and it becomes self-perpetuating.
Yeah. Yeah, why don't we switch gears a little bit here and tell us more about the Society of Robotic and Laparoscopic Surgeons. You're
So
the
the
chair.
society, yeah, SLS, the
Yeah.
Society of Laparoscopic and Robotic Surgeons, was actually founded in 1990. And originally the word was laparoendoscopic, which actually is a word that yours truly coined, when we started a journal with Marianne Liebert in 1990, trying to embrace laparoscopy and endoscopy as surgical techniques and technology. So the journal. The Journal of Laparoendoscopic Surgery and Advanced Technologies, JLAST, actually came out in October of 1990, and SLS was founded in December of 1990, using the same word. But the point is that the organization was started by Dr. Paul Wetter and two other colleagues, with the concept that people from different disciplines and specialties can learn from one another. And so he brought together, he's a gynecologist, himself, general surgeon, and urologist, as a group, to come together and talk about techniques and technologies. And very, very early on, interested in so how do you do this properly? How do you prevent and manage complications? And if you look at the annals of the society, if you will, the society's published several textbooks on that, and we've done several courses and so on. So the group is, I'd say, more clinically oriented in terms of solving clinical problems as opposed to basic research. But it is a global organization. And in terms of embracing technologies, the folks who are the KOLs, and some in lasers, myself, but the Najats, Charles Coe, others, have been in the leadership of the society. Dr. Richard Satava, is actually the person who funded what has become intuitive in the Da Vinci robot and SRI through his work in DARPA, and many others. So we brought together a bunch of knowledge and opinion leaders in leadership, but in reality, an organization that is, I'd say, almost a family, in that it's very collegial in terms of being able to exchange ideas about techniques and technologies.
Yeah, that's great. And this year's meeting, you have an annual meeting. When's this year's meeting? Is there a theme for the meeting?
So this year's meeting is September 10th through 13th. It'll be at the Wyndham Lake Buena Vista Resort in Disney Springs. The theme of the meeting, if you will, is where disciplines meet, or where laparoscopy and robotics meet. And like we were talking about with lasers and laser technology, there's people who try to be lumpers and splitters. So there's the concept of, well, if you use a robot, then you don't use straight stick stuff, which is 2D optics and laparoscopy. But that's not necessarily true. And so we embrace those techniques and technology. And I think if you look at the spectrum of papers being presented, you'll find pretty much an even mix. Probably these days more skewed toward robotics, because that's where the state of at least some of the clinical academic interest is these days, as opposed to some of the more basic laparoscopic applications.
That's great. Yeah, and I know that, there is a lot of laser work there, and it's a good place for people looking into getting into lasers, combining it. I think it's a great meeting for technology development, right? There's a lot of different disciplines there you can learn
Right.
from or collaborate with.
Right, and one of our featured speakers is Dr. Raul Rosenthal, who's now at UCLA, I believe. But he is internationally recognized relative to the applications of fluorescence guided surgery. So it goes around and comes around, that these technologies are coming together. And like I said earlier, that's part of what makes me tick. So it's a lot of fun for me, very gratifying to see some of these things come to fruition. And in some case, people rediscover those techniques and technologies.
Yeah, that's great. So a couple of questions we kind of ask all our guests to get perspective on is one is what advancements are you excited for or do you see in, say, the next 3 to 5 years?
Um, so I think in terms of, if you asked me on the subject of um, computer assisted technologies, aka robotics, there is a literal explosion of those technologies out there. I think at last count, there are about 60 companies coming online or will be online. Some of which have some very interesting ideas. Uh, I hope some of that will translate into the marketplace. My sense is that unfortunately most of it won't, because of the way the marketplace works. But there's some really great techniques and technologies out there. We're on the cusp of seeing um, folks embrace the antimicrobial photodynamic therapy paradigm for a lot of reasons, because of antimicrobial resistance, among other things. Um, I hope in the near term future, people will again decide to pick up fiber optics and lasers and marry them to robots. I think that's a perfect thing, or can be, and I think we're on the cusp of that, um, possibly in part because of the interest in fluorescence and some of those tools. So I think there's a window of opportunity there uh, for that to happen. Um, like we talked about in the realm of PDT, being able to better target tumors and structures, and being able to light activate, being able to sequence therapies. That's coming. PBM wise, the technologies are, I think, much more available. And um, not that they weren't credible before, but I think there's several stable manufacturers out there, which is good. And people have done and continue to do some serious science. So I think you'll see more there. I could go on, but but
That's
but
great.
but those are they.
Yeah, I think it is an exciting time. And then with AI on top of it all, right, for diagnostics and other things, it's gonna
Right.
it's gonna be
Yeah.
really, really interesting to follow. So our last question is, what brings you joy, either professionally, personally, or both?
I think, well, not family notwithstanding, being able to spend time with good family and friends, um, being able to solve problems and make a difference in a positive way, I think is one of the things that's brought me the greatest joy and continues to do that. Um, um, and since I'm an old guy, probably being able to reminisce about some of those things and chuckle to well, it wasn't new when I saw it back in 1980, and it's not new now, but it's kind of the Mark Twain thing about his how much his father learned. And think to myself, yep, they probably said that and continue to say that about me, but it's good to smile.
Yeah, no, I think that's important. I think, like you said before, sometimes the market's not ready, right? Or sometimes just a small piece of the technology is not ready. And a lot of these things, fluorescence, I mean, Raman, right? We've been doing this for a long, long time. And it just might take the killer app. It might take one piece of technology. Like, I don't know what it is, but we've both been in meetings where hot topics were hot in 1980 and they're still hot. So
Yep. Yeah. Yeah, absolutely. And and some of those things you just scratch your head. It's how you look at the problem. And I think it's a rare person that really can look at multiple facets of things and say, well, okay, this is the thing. If I do this, then B, C, and D might happen. I ought to think about that. And be prepared to deal with that. And I guess as a surgeon, you're trained into part of that, but not everybody has that capacity as well. Um, you know, in whatever it is you're doing, and those who do, I can't say always are able to successfully read the tea leaves either. So I guess it's part of human nature.
yeah.
Yeah, that's been a very interesting and thought-provoking talk. I have to thank you, Dr. Lanzafame, for your time today. I'm sure as your meeting becomes nearer and nearer, your time is becoming more and more precious. So we wish you the best of luck with that meeting. People who want more information, I think www.sls.org would be the place for them to go to find more information. I want to thank BW Tech for sponsoring this, and any information can be gained from info@aimla.org. We welcome correspondence. We welcome feedback on our podcasts, and suggestions for topics or speakers are also welcome. But again, Dr. Lanzafame, thank you so much for your time today.
Thank you. Thank you so much. I've really enjoyed the conversation. It's great to catch up with you all, and wish everyone well.
Thanks, Ray.
Thanks so much.
Thank you. It was fun.